My brief was to talk about knee pain and arthritis, and I thought it was a fairly dry topic, really. So I've tried to make it as varied and interesting as I can. And first, I see knee pain obviously, all day, and I still remind myself about things that I can't miss. So I'm going to talk about that briefly, and then a rundown of the relevant anatomy. I'm a big fan of X-rays for everyone for various reasons, and I'll go through that, and then some cases and some talks about knee pain as well. And the other thing I've tried to do is emphasise, because I've done quite a lot of tele medicine, and which I don't love, but I've tried to emphasise things where you can do, this business of being an orthopaedic surgeon, a lot of it by history and observation of people's walking and standing and various tests that don't need any particular hands-on or any particular examination skills. Because I think you don't need much in the way of examination on the couch. Most things are evident without that. So that's what I've tried to emphasise. So just in terms, so for me as a knee surgeon, every day for me it's not to miss hip pathology and not to miss tumours. I see hip pathology a lot, mimicking as knee pain, and I hardly ever see bone tumours. But I look like a real goose if I don't work those out, or a duck. So with hip disease, you've got to think of it all the time. You all know that because of the nerve supply to the hip, we get radiation of hip pain to the groin and thigh, and down to the knee. But occasionally it presents just as knee pain, and that's where we get trapped. So remember the duck proverb. So we all know this one, if it looks like a duck and walks like a duck, it's very likely to be a duck. So, and look at this guy in the middle. He has really got bad duck hips, that guy. So he's waddling all over the place. And so if it looks like a human and walks like a duck, it's probably got a bad hip. So just remember, and it's interesting, the ones that I see, a few a year, who present with only knee pain and they've got a bad hip. It's interesting that often it's the thing that strikes me about them is the incredible disability they have and the very bad waddling duck gait that they have. And I can see them coming in from the waiting room that they've got a bad hip, and then they've got a referral about their knee, and I think, well, that one's easy. But some of them aren't that easy. So this woman's got a bad hip. It happens to be the left hip. And hers is not the most obvious. She's not the worst. But when we see people walking down the street, just in Rundle Mall, and they walk like a duck, they've all got bad hips. So it seems that we should be able to pick it up when they've come into our office and we're orthopaedic surgeons or physios or whatever we are. This lady was, who I've treated recently, had knee pain for years, and someone finally thought she had a bad hip. In fact, it was a physio. There's a lot of physios here, so I'll give a plug to the physios. And she came along, and I looked back through her x-rays and stuff, and she had quite a few x-rays of her knees over the years, and MRIs of her knees, and these are hers, which don't look too bad. And then eventually someone looked at her hip, and she had this hip. And that's the other thing about hips, which is interesting. The ones that present with knee pain often have these very bad subluxated hips. I don't know why they present with knee pain, these ones more than the others, and I don't even know if that's true. It just seems to be my experience. But this woman had a dreadful gait, as you can imagine, and terrible, almost wheelchair bound, and only knee pain. So I think it's a big one. And this is a classic in the adolescent boy. This is the slipped epiphysis on this side. So don't miss this with the hip that's irritable and doesn't rotate internally, or you might end up with this. And then we're going to look really foolish. So we have to think about it all the time. The other thing is tumours. So bone tumours, compared to my normal practice, are really, really uncommon. But because of where I sit, I can't afford to miss them. So the main thing for me to not miss them is to x-ray the patients and to just keep a vigilant eye on them. The symptoms could be anything. It's just always keep it in your back of your mind if the clinical pictures doesn't fit, and doing x-rays, it's one of the good reasons to do x-rays. And bone tumours occur a lot around the knee, primary bone tumours, and they occur a lot in adolescents. So we have to watch that. Yeah, I said that. So this is a magnificent x-ray. This person's got the lot. But a lot of tumours occur around the knee because it's the biggest growth centre in the body in adolescence. The distal femur is, and then second is the proximal tibia. So in terms of x-rays, look, I think x-rays are just so important, and it's also very important to get the correct ones. So you always need 4 x-rays: AP standing, both knees, lateral, skyline, intercondylar. It amazes me that sometimes the radiology companies don't do 1 or 2 of the x-rays, and they don't even mention it, and then they report it as if it was there. And it's like you can't be serious. You can't report a normal knee x-ray when you haven't done a skyline or whatever, but they do. So get them all done all the time. It's not, and the reason is that the AP standing is to compare one side to the other and to have weight bearing. That's sort of plainly obvious, but it still doesn't get done sometimes. Like look at this one on the, this is the same knee x-ray at the same time. So without the weight bearing, you don't see anything much on the non-weight bearing view because of the lack of weight bearing. Or this one. The intercondylar view, why do we want the intercondylar view? It's done like this, and it gives us a really good look down the notch. I'm trying to move something out of the way. So just see, we get to see down the notch, and that's great for osteochondritis dissecans and loose bodies hiding there. And there's the difference in the views. You see, you just get this great profile down that notch. And lateral OA often looks much worse in a flex knee view because the wear is often a little bit more posteriorly. So that's one good thing. Osteochondritis shows up. Look at one view compared to the other. You can hardly see it in this view, and then it's so obvious in this view, and so are the loose bodies. So get the intercondylar view, and the skyline, obviously, to look at the patella, and the lateral to look for everything else, blah. But just gives us a lot of information about patella height on the lateral and subtle signs for patella instability, which I won't go into right at the moment. So just let me run through a bit of a quick review. Does anyone actually want to butt in? So please butt in. And
yeah, Richard, can I just ask, when you request that X-ray, do you literally write out AP, lateral, skyline, intercondylar, all 4 words, or is there a way of saying you want all 4 views without typing every single one?
Yeah.
What do you put on your request?
I've got a sticker. It's got a little tiny sticker.
Right.
Because I think I've got sticker writing it.
Yeah.
There's not a standard, unfortunately.
Yeah, I guess that's what I was saying. The radiologists don't have a standard thing that they would understand.
No.
Okay.
There's one excuse for not doing a standing X-ray, and that's
if they can't.
If they can't stand.
Yeah. Okay.
So does anyone else want to butt in? Not butt in, just contribute. Okay, let me just quickly go through a bit of a tour. We have to always remember the patellofemoral part of the joint. In a practice like mine, you know, I do see patients with MCL strains, possibly, but you don't get MCL injuries unless there's usually a trauma, and they don't last for ages. So people with medial joint line pain without trauma that lasts for ages and is intermittent and goes on and on is not usually MCL pain. It's usually something related to the intra-articular structures. But just a view arthroscopically of the patella, gliding, and so we see a lot of patellofemoral disease, whether it's arthritis or chondral disease like this. This sort of person is going to have normal X-rays and a lot of crepitus and a lot of patellofemoral symptoms. Doing this to the patella is a sort of a last treatment rather than a first treatment. But when they've got a lot of grinding and recurrent effusions and they've had all their non-operative management, gently shaving very rough cartilage helps quite a lot in the selected group. And just remember that the meniscus is sitting in between the articular surfaces. It's vascular around the edge, so it can heal around the edge. You can see the vascularity around the edge, but the interior is avascular, and so is the articular cartilage. And that's why meniscus tears like this never heal, because they have no blood flow, they have no healing capacity whatsoever, and they act to irritate the joint and the synovium. So you get a localized synovitis around that tear is because of the instability of those fragments. So why do we do this procedure? Because it removes the useless meniscus, which is basically an irritant and giving no benefit to the patient at all. And arthroscopies got a funny sort of a bad name at the moment, but doing a procedure like that on the correct patient can be so much improvement in symptoms. It's like a miracle.
Richard, can I just ask?
Yeah.
Excuse me, the crepitus that you talk about with the chondral surface of the patella. Do you notice that when you do that, that it changes that crepitus? That it goes away, reduces?
Yeah. It reduces it.
Yeah.
So I always tell them that they'll have crepitus afterwards. What we're interested in is less crepitus and less effusions and less pain.
And less irritation, obviously.
Yeah, and the main thing is if you smooth the surface, it doesn't catch, you don't get chondral shedding, you don't get synovitis, and you don't get the synovitic pain. So, clearly the structures has no neural supply, but its effects are through the synovitis and the effusions. So if we can smooth it, it certainly makes a difference in the right patient. Torn ACLs, my talk's not about sports injuries, so I'm not going to say much about that. But most of the diagnosis of things is in the history. We know to ask about pain and the location of the pain and the aggravating features. They're probably how long, what precipitated it, where's the pain, and what's the associated swelling and activities that irritate the knee. We do functional assessment as part of every history in terms of what's the disability, what can't they do, what are the activities. In terms of arthritis, it's about their walking distance, their ability to play bowls, their ability to get up and down from chairs and do stairs and community things. And in younger people, it's more about more challenging things such as how they're going with their sports. But it's a functional evaluation. again, patellofemoral disease is just so common, and it's very honest patellofemoral disease in terms of the symptoms that it gives, particularly functional symptoms. So if you ask them about stairs and steps and kneeling and squatting and all those sort of things, and if that's associated and going up and down hills and stuff, if they've got patellofemoral disease, they almost invariably will tell you or will respond that their symptoms are worse with these patellofemoral activities. So in terms of examination, I think you can do most of the examination just by looking, getting them to walk and getting them to squat and do a few other things. If you've done a history and you've looked at those things, you'll pretty much get the diagnosis most of the time. So let's just go through a few things. An obvious effusion, it's in the suprapatellar region, so it's a big intra-articular effusion extending up into the suprapatellar pouch. It'll be bulgy on the inside, and it's pretty obvious compared to the other side, as opposed to this appearance, which is very more lobulated appearance in the front of the knee, which is due to prepatellar bursitis. That's this bursa up here. Now, standing coronal alignment, when I teach the students and stuff, it's my big thing, because if the standing coronal alignment is abnormal, one side different to the other, it's 95% of the time or more it's arthritis. So if it's varus malalignment like this guy, he's got medial osteoarthritis every day of the week, and if it's valgus malalignment, he's got lateral osteoarthritis. So it's pretty simple, and if they're young people and they've got some bilateral symmetrical varus or some bilateral symmetrical valgus, well, obviously that's different, and that's just within the normal variation of parameters. But when they've got unilateral, and particularly when it goes with a loss of full extension. Again, one of my big things is extension. If the knee doesn't extend fully for any reason, and that's with arthritis or post-operative or post-ACL or whatever, the effect on the knee is massive. It affects the gait, it affects the patellofemoral joint severely, it affects the quadriceps function. So a loss of extension, and that's why these are the things that you see with people standing. You ask them to fully extend their knee, and if it's a guy like, this is so obvious, but subtle losses of extension are what we see with early arthritis, and subtle losses of extension with pain is what we see with lateral meniscal tears and medial meniscal tears. So these are the things, and you can do this. You can do this telemedicine, COVID style. So this is something we look for effusions, and we do the movement. I'm focused. This talk's a lot focused on not the examination we do on the bed, but we do this. We do all these collateral testings. We test for drop back, and we test for the anterior cruciate ligament. This position is the position which we look for the posterior cruciate rather than the anterior. We look at the station of the knee, whether the knee's sitting in the right position. It's not a good position to test the ACL, but it's a very good one to test the PCL. This is how we test the ACL with the Lockman test. So this one is normal on one side, but it's pretty sloppy on the other one.
It's gross.
It's gross, yeah. And this one
You see that bad jerk?
is a bad pivot shift test.
Hold on. Yep.
But just showing the rotational problems that we get with ACL injuries. So again, patellofemoral, we need to look at the patellofemoral joint. A lot of it's in the history. We see patellofemoral disease, we see people with arthritis of the patellofemoral, and we see people with instability, and we see people with chondral disease, and then we see a whole lot of other associated anterior knee complaints like, fat pad impingement and pliques and stuff, but a lot of it comes down to being patellofemoral. Now, most of them won't do this for you in your office, but this guy's got a bit of a problem. This is more subtle, but again, best seen without touching them again. Just sit them on the edge of the bed. I always sit them on the edge of the bed and look at this J tracking. So watch him in extension, just come up and slide and then J track down again. So quite bad patellofemoral malalignment in that sort of knee. And patellofemoral malalignment, I'll just go back to that. I'll just go back one. If you have patellofemoral malalignment and the whole thing with lateralized tibial tubercle, subtle patellar alter, trochlear dysplasia, this sort of family of things that you get, you get instability. But if you've got patellofemoral malalignment and you don't have trochlear dysplasia, you get lateral patellar stress, and you don't get instability, but you get lateral patellar stress and chondral wear, and eventually patellofemoral arthritis. So, often whether you get arthritis or instability is just related to how good your trochlear is. So, but they're kind of in the same family a lot of the time. So let me go through some things. Now, let me pause there just to see if we can have any discussion about anything on that.
If you go back to your discussion, Richard, about arthroscopy, you mentioned, of course, it's fallen out of favour, and most arthroscopies are done for the wrong reasons, or many, I should say. But you've obviously also said that there are certain meniscal tears that should be repaired at arthroscopy to prevent future synovitis, arthritis, and further knee problems. Which ones do we refer?
Oh, okay. So that brings me to the elephant in the room, which is this. So I think what happened with arthroscopy is, to be fair on the whole thing, it got overused and abused quite badly. And like all things, if you do that long enough, someone's going to pull you up and say, what's going on here? You're doing a useless operation. So the pendulum has swung. In my view, it's gone a bit far in the wrong direction, and the balance, like everything, somewhere in the middle. So I think it was being done just for every Tom, Dick and Harry. And I used to see people who'd had 5 arthroscopies in 10 years, and it was just ridiculous. So it was definitely overused and abused. The thing about meniscal tears, and I've got a couple of cases, is the commonest thing that we see is medial meniscal tears, and unless they're quite rare, most of them are not repairable, and so they get arthroscopic partial meniscectomy. Now, if you do or you don't do that procedure, it doesn't save the joint from getting arthritis, and if it's done properly, it doesn't make the joint get arthritis. I think it's fairly arthritis neutral if it's done properly for the right reasons. But it doesn't hurt to leave the meniscus tear and see how they go with it. And if their symptoms aren't bad enough, they don't really warrant an arthroscopy for a meniscal tear, because its benefit is in symptom relief. So if they've got pain, they can't squat, they're disabled, they've had it for a while, they've had anti-inflammatories and it goes away and then it comes back again, and then they can't squat and they get a lot of pain and they're starting to get night pain. Well, there you can make a very good case for it for those people, because it works brilliantly. And then there's the other group who have some degree of arthritis but have a meniscus tear on top of it. And then they've gone from someone with a bit of an achy knee from time to time to now an achy knee, but sitting on top of that are these quite florid meniscal symptoms. And they do very well with arthroscopy as well. The ones that don't do well at all are the ones with chronic arthritis and chronic arthritic symptoms, non-acute, and it's basically the achy knee, the chronic achy knee. And the achy knee, the ache comes from the bone, and in the meniscus tear, the pain comes from the synovitis. So, you know, from a pathophysiological viewpoint, we've got to try and work out the difference in that and treat the patient accordingly. So this person is 42, right knee pain, worse with squatting and a bit of swelling. So 7 months, not much of an injury, but relates it back to a time when he was doing a lot of gardening. I can't quite remember. Typically, they relate it back to something. And when you look at him, he's got perfectly normal alignment, and he can nearly extend. But if you look at it critically and ask them to really push into extension, both knees at once, you'll often see they'll go into extension, but they don't really like it. That's typical of a meniscus tear. Not a sign that's as well sort of recognised as deflection signs. And then if you get them to squat, which I always get them to squat, fully squat with their knees closed, and they often, it just hurts doing this. And if it doesn't hurt, I get them to bounce on it. Now, that's a much better test for meniscus. So forced extension, standing and squatting is much better than any McMurray's test because it's a loaded test. So this guy, normal alignment, hasn't got arthritis, got almost perfect range of motion, hasn't had symptoms. You know, he's going to have a meniscus tear every day of the week like this. And you can see that sort of split through here, and you can see it on the lateral coming up through the bottom of the meniscus up through here. So it'll never heal. He's got perfect chondral surfaces, and if his symptoms are annoying enough, I will certainly offer him arthroscopy, and the chance of him doing well is in fact very high. Yeah, that was him, normal x-rays. Oh, arthroscopy, this sort of thing. Take that bit of bad meniscus out, and he's still got 2/3 of his meniscus doing quite well. So then, you know, this lady is 63 years old, who I've just treated, very fit and active, chronic patellofemoral symptoms, but new symptoms for only 9 months of medial-sided knee pain. So chronic symptoms, anterior knee pain, worse with hills and squats and lunges in the gym, and doing stairs and steps, and crepitus, but managed for years, has never come to anything, but 9 months of new medial-sided knee pain. Very common story. Exam shows slight varus, a lot of patellofemoral signs, and medial knee pain with squatting. So her x-rays look like this. She's clearly got chronic patellofemoral disease with that. She's got lateral patella subluxation and some slight joint space narrowing on the lateral aspect here. And she's got some arthritic symptoms. She's got very subtle narrowing. She's got some spurring of the margins. So, you know, according to the New England Journal of Medicine, she doesn't get an arthroscopy ever because she's got arthritis in her knee. But she's got this sort of MRI. She's got no cartilage on the lateral facet of the patella. Good chondral surface, mostly good chondral surfaces in the tibiofemoral. Terrible meniscus tear here. And does really well with an arthroscopy. Once she's had a trial of non-operative management, which is appropriate. But we know a lot of these ones that if they have non-operative management will do quite well, but the meniscus won't heal and their symptoms will often return. And I'm more than happy for them to just try the non-operative management, and if they need to come back, they'll come back. No, it's no problem. Nothing lost. But we do need to treat, you know, a lot of meniscus tears non-operatively initially to give them a chance to settle. And we do need to treat, you know, the underlying osteoarthritis that we see so much in a sensible way with what we know is sensible programs. And weight loss makes an awful awfully big difference. So do anti-inflammatories. And our physios at the Wakefield Sports and Exercise Medicine Clinic, a whole lot of them who are listening. The GLAD program is from Denmark, and it's a specific program for osteoarthritis of the knee and hip, and it's specific neuromuscular physiotherapy. It's, you have to go to a course of it, but it's got some science and some studies and some data showing that it works. So it's certainly worth exploring all those options, and weight loss and exercise and emphasizing people that they have to get their weight down and that they have to do low impact exercise is just so sensible that it seems ridiculous to have to say it, but people need to hear it. Do you want to say anything about the, Chris, I can see your face there, about the GLAD program while I sip my coffee?
No, I can completely agree. It's worth trying conservative management. The GLAD program is the one way of conservative management of arthritis. It basically is strengthening and education that goes along with it. It's, as you said, Richard, activity modification. And it's not to say, excuse me, it's the only way. There's, as long as you get some strength, some good education through it, you can make a difference. But the nice thing about GLAD is we measure things before and after and see if it's made a change and it has some structure around it. And if it doesn't work, then that's fine. Nothing, like I say, nothing lost. I think that going back to the elephant in the room, Richard, the way you described how you would, why and when you would do an arthroscopy makes it clear that if you use good, sound clinical reasoning, then it's it's a useful, absolutely useful tool. And the way you talked through that, the people run into trouble with all things, not just arthroscopy, but things that we do at physio, if we just do them and don't think about why we're doing them. So, yeah, thanks. Good point.
Thanks. So, so the GLAD program is, it's a series of about, how many visits? Is it 8 or 10 or?
They do 6 weeks, 2 classes a week.
Yeah.
And reviewed
12 visits with 2 education sessions. Sorry.
No, thanks, Ken.
I think we were just talking about weight loss, Richard, and we've just provided a small extension of the education recently by getting one of the obesity doctors through REU to be involved in providing an extension lecture to GLAD participants through Wakefield Sports and Exercise Medicine Clinic. And this has been going on for a little while now, and we think people, once they've been through the GLAD program, are getting a lot more good information to really assist with their weight loss by going through that lecture. And because the actual GLAD program itself doesn't have a massive focus on the actual practicalities of how someone might go about effective weight loss. So getting those experts through REU to sort of provide something into that program, we think has been a good value add for patients.
Yeah. Thanks for that, guys. Yeah, I mean, that's the thing. I see people with meniscus tears who are very overweight. I tell them that, that they should lose the weight if they can first, and then look at see how things go. Very overweight people with meniscus tears are the ones that can do quite badly after arthroscopic meniscectomy. There is this incidence of getting avascular necrosis, whether that's due to the arthroscopy or just the insult or the meniscus problem. It's hard to know, but that's another it's another caution light for us. And so I'll often say, look, if you don't get the weight off first, you might not need an arthroscopy, and if you need an arthroscopy, you'll do so much better if you're not not so heavy. I'll come to alignment in the knee, but the knee is so sensitive to being overweight and malalignment, and these things all go together. So it's a big thing. So where am I up to here? I'm a little bit out of order, actually. What I wanted to talk about was the next patient on my list, who was, I've lost a slide, I'm sorry, but she's a 42-year-old lady who presents with chronic severe patellofemoral pain, and she's got very good tibiofemoral joints here, and her pain is all patellofemoral. She can't get off a toilet seat. She can't do stairs and steps. She's only 42. She's a bit overweight, and she works as a nurse. And here she is with this, terrible patellofemoral osteoarthritis, which is due to malalignment, and she's had lateral patellofemoral, stress syndrome for years, and it's completely worn out the lateral side of the patellofemorals. So what do we do with someone like this when they've reached the end? Now, she's had an arthroscopy many years in the past. One thing for sure is an arthroscopy is a complete failure here. So you just wouldn't even bother with it when things are that mechanically deranged and malaligned. So your options become very limited there. Patellofemoral joint replacement hasn't done well in the joint registry. It's had a lot of failures and early revisions. And total joint replacement does do well, but she's 40-something and has a good tibiofemoral joint. Now, patellofemoral joint replacement, a lot of you won't have seen a lot of, but the concept's pretty straightforward. Replace the trochlea and replace the patella. But as I said, it hasn't done well. So, it's not something that I've done because I don't like the results of it in the joint registry, and they might get better over time. Lateral release won't work for her either because the mechanical derangement is too great, and lateral release won't do anything for her. Now, I'm a big user of tibial tubercle transfer for people with patellofemoral pain because it's a true realignment operation, and it's the way that it's done now is it's a fairly low morbidity. It sounds a lot, but it's not. It's not a very difficult procedure the way we do it. So look at that patellofemoral malalignment. But the articular cartilage on the medial facets here is quite good. So the tibial tubercle transfer literally involves moving the tibial tubercle across often a centimetre or so. And it's amazing the effect that it has. And I didn't used to do it that often when I was in my younger days of practice, but the more I did it, the more I was amazed how much it helped. And what amazed me was how quickly the night ache disappeared. And it's another thing with total knee replacement and also tibial osteotomy for osteoarthritis of the tibiofemoral joint, how quickly the night pain disappears. It's just quite amazing. And this is the worst case I've ever done a tibial tubercle transfer on, because it looked terrible. But more and more, they've done well. And this lady did so well so quickly that her range of motion was better, her pain was better, her ability, she could go up and down stairs without hanging onto the rail. So, quite amazing. So I've been more bullish on this sort of thing. Here's another person who hasn't had anything done. Now, so I wouldn't be, this is the same thing, but far less. I think this person would do well from patellofemoral realignment because you can see it's all lateral patellofemoral stress.
So, Richard, did you have any post-op views, skyline views of the previous lady? Just out of interest.
I didn't show them because they don't change.
Okay.
Yeah.
Yeah.
They don't change, and because there's nowhere else for the patella to sit, except over there. And
Yep.
because it's a 10 millimeter movement, you know, I kind of hoped they might, but in effect, I thought they wouldn't. And, you know, that's the reports say they don't change much. But
I guess it's a static sort of shot of it anyway. It doesn't show.
It's a static shot, and it doesn't show how much load is going through there as you move. And so it must be a load thing. So this is that other case. See, a very severe patellofemoral disease here, but really good articular cartilage on the medial facet. Now, I'm sure we're not loading the medial facet beautifully, but we're certainly unloading this, because the tibial tubercle goes across around 10 mil, but you also make it go up a little bit at the same time. So just reducing the forces there, and again, makes a lot of difference.
Richard, ultimately managing patellofemoral pain is all about managing load through the joint. And if you can transfer that load even by a few degrees, you're going to make a difference.
I think that's right. I think that's right, Andrew. And the other thing is, those people with the patellofemoral stress and malalignment syndrome, if you look at their tibial groove distances on CT, like I showed the CT before, or if you do MRI, there's another measurement on MRI which relates to the PCL and the trochlea. They do have lateralized tibial tubercles, and when you do a total knee replacement when they're older, which they will all come to presumably if they live long enough, they've got better patellofemoral alignment for the total knee because you've already done the tibial tubercle transfer. So that's a little aside where the operation, makes some degree of sense. So if we move on to just some other cases, so what do we do with the young man with the early medial osteoarthritis? And, here's a case where there's clearly medial osteoarthritis. And as I said, the knee is such an interesting joint in terms of, once you have osteoarthritis and a partial meniscectomy, it's starting to tip into varus. And as soon as it tips into varus, the load, the center hip, center ankle line, suddenly, instead of going through center knee or somewhere around here, is just tipping across. So it really is a vicious cycle of the more arthritis you get, the more load you get, and the more malalignment you get. And this is this person. In fact, this is the person who I'm treating actually today. So this lady who had this arthroscopy 10 years ago has now tipped into a bit of varus. And you can see that the center hip, center ankle alignment. She's not that bad actually, because she started off with very good alignment, even tiny bit valgus as her natural alignment. She's not in much varus at all, but she's quite young and active, and she's in her early 50s, and she's slim, active, and the rest of her joints really good. Oh shit, I'm a bit out of order, sorry. So she's down at the moment for a high tibial osteotomy, just to correct her thing. And again, like tibial tubercle transfers, the osteotomies work very well just to take the pressure off the joint. So that's opposed to someone like this. Again, the beauty of just looking at them walk, she's got a very straight right knee, a very varus left knee, and she's got a varus thrust, which means there's a dynamic increase in varus when she hits the ground. So, you can, the mechanics of that, there's so much stress going through the medial compartment. And in fact, there's no load going through the lateral compartment at all. So it's no wonder they get so much pain. But just coming back to the more subtle forms of where you've got unicompartment osteoarthritis and tibial osteotomies. Again, as I showed, as soon as you get this joint space narrowing, it shifts the weight-bearing line into the diseased compartment, and they get no wear or stress through the undiseased compartment. And that, that's why tibial osteotomies, work so well. And in Australia, we haven't used them anywhere near as much as they use them in Europe. It just wasn't a big part of our teaching, I don't think, but a procedure that works very well. This is an opening wedge osteotomy that we do. There's different ways to do it, but opening it is, changes the alignment. So this is a left knee medial compartment where you can see the medial compartment is closed down here. So if you wedge the tibia open like this, and we put a little bit of bone graft in here, it'll change the mechanical axis, say, from this point here. And what we do is we can quite accurately determine to put it just over here, which means it'll just hit the downslope on the lateral side. So when the foot hits the ground, it'll just drift that weight bearing into the lateral compartment. And of course, it'll wear the lateral compartment, but it's all about saying, well, look, the medial compartment's hammered and worn out. So let's give the lateral compartment hopefully 10 years of use. And when you've worn out both, you can have a knee replacement. And we don't expect perfect results, but we do get good relief for years. And this is a sort of blurry thing, but this was a right knee that was done. And we're getting the weight-bearing axis down here. So the one I do today, we've pre-planned how to get the mechanical axis down in this line. And I have used it a couple of times, and I'm using it today. You can use the navigation systems that I use for total knee replacement. You can use them when you do osteotomies, and you can adjust make sure using the navigation that you've got the access where you want, so you can fine tune it, intraoperatively. So tibial osteotomy, and there's one of the reasons people don't love the operation is that it's got a high complication rate of fractures and nerve injuries and non-unions and things that, if they occur, are a bit of a disaster. So unfortunately, traditionally one of the highest complication rate operations in orthopaedics. So perhaps that's why we don't do it that often. But
so Richard, sorry to butt in, is there much of a case for doing a unicompartmental with cases like that? Is that what some surgeons would choose to do?
Yeah. Well, I think it's that's the whole thing about the selection is, I think when you've got severe medial compartment osteoarthritis, you've got, after all your non-operative treatment, you've got to consider osteotomy, uni or total. And I think you have to base that on all your experiences and what you favour and what you're good at and all those sort of things. And I think you'll find, Kim, that if you think what happens to the patients, that it probably goes down to surgeon preference a lot. But so my algorithm is young males, especially if they're like in their 40s and they're males and they're fit and active, they'll beat up a joint replacement so quickly, whether that's a uni or a total. So I'd rather, if they're young and active, do the osteotomy. And then if they're old enough to have a joint replacement, then you've got to decide whether they want a uni or a total. Now, I stopped doing unis about 10 years ago because the results in the registry weren't quite good enough, but they're getting better now. So I think a uni, but so the results of total joint replacement are functionally better too. But I think between joint replacement, whether uni or total, and osteotomy relates a lot to age. And because, of course, once they've healed their osteotomy, they can go as hard as they like on these, and then they can have their total knee. So that's, I think, that's the beauty of them.
Richard, two questions about unis. Firstly, I was always sort of talked about unis in that they were a time playing for time procedure. In other words, a bit like the osteotomy, you're putting it in and you can come back and revise it later. Comments on that. And secondly, from a technical perspective, is it more difficult to revise from a uni to a total or from an osteotomy to a total?
Yeah, I think, good questions. Well, firstly, the trouble with the unis is the good ones were doing fantastically, but the bad ones get revised, and it's a technically that needs to be done incredibly accurately. If you overstuff it, they go into valgus and that it doesn't work. If you undercorrect it, they tend to wear too hard on the medial side. So it needs to be done very, very precisely. And I think that's where navigational will show a way forward, or robotics, which I've started to look at, because I think the results will end up being a lot better that way, because it's very, very very sensitive to the end alignment. A uni. The trouble with this business about you just do that and then you convert it to a total is that the results, if you have a uni and then it goes to a total, the results of that total are much inferior to the results of if you had a total in the first place. And the revision rate of the total after a uni is much higher than the revision rate of a total that was done primarily. So they're the problems. And it's like people say that what you said, as if there was no downside or you haven't burned any bridges, whereas in fact the literature doesn't support that. So that would be my comment about unis. It is relatively easy to...
Love you guys. Have a great day.
So it's relatively easy to convert a uni to a total, but you need a stem in the tibia. So it's not a standard total knee replacement. It's slightly on the way to a little revision on the tibial side. And the failure rates are just higher than a primary. So it's not that technically difficult to revise it, but its results aren't as good if you watch them. As far as converting osteotomies to total knees, it's definitely more difficult to do a total knee after an osteotomy, particularly a lateral closing wedge osteotomy, because they have abnormal tibial slope. They often have an anterior tibial slope. They have patella infra and patella scarring, patella baja, all those sort of things. So yeah, none of these procedures come with a no bridges burned guarantee. They've all got their difficulties. If that answers the question, Andrew. We're just about out of time. This lady's, the valgus arthritic knee, again, just so obvious without even examining them on the bed. These ones get pain radiating often down the lateral edge of the tibia, and again, the mechanical axis is so deranged here. With the valgus knee, they tend to go quickly into more valgus, and they quickly decompensate. And just walking then. And she's got a total on the other side, actually, which she had bilateral valgus knees. She was born with them, and she wore them out, as they do. But that's not her x-rays, but you can see the mechanical derangement. But they do really, really well with total knee, because they need to be corrected to a mechanical axis alignment of neutral, of 0. But that's easy enough to do, and they do fantastically well. And they often need their patella. They've often got, with that valgus, they've often got lateral patellofemoral wear that's quite severe. So they often have severe patellofemoral symptoms as well. So do you know what? It's 25 past, and I feel like I've said enough. And we can do osteotomies for valgus young people as well, like lateral opening wedge femoral osteotomy. But I feel like I've done enough, so I might just leave that slide up and just see if there's any questions.
Can I just ask, is the patient-specific knee replacement thing, is that a catchphrase, or is that something that is a term for the sort of alignment statistics that you're referring to? And if it is a specific thing, what's the role of the so-called patient-specific knee replacement?
Well, there's the one where they get the scans and they make a jig which fits on you, helps you do the cuts. The accuracy of patient-specific jigs is not very good, particularly in rotational alignment. So I think it's been shown in a number of studies not to be that accurate, the patient-specific jigs. And I think it's going to be quickly run over by navigation and robotics because it's more accurate.
Okay, yeah.
Yeah. And also navigation and robotics navigation's just got a lot easier.
Yeah.
So, and it's all sort of very dynamic and adjustable, and in real time. Once you've got a patient-specific jig, you've got it, and you whack it on, and it certainly had some advantages in terms of much less inventory and things, but it's just I don't think it's accurate enough to be of any great long-term use.
Right.
One of the things tried in the evolution that I think will die away, I think.
Okay, thank you.
Richard, one question about the patella surface. When you do a total and it's a really arthritic patella surface, do you leave that, or how does that sit in the...
No, I think the patella needs to be resurfaced. If it's very arthritic, and if they've got a lot of patellofemoral symptoms preoperatively, probably do more patella resurfacings than I used to. I think I used to do 5 or 10%. Now it's more, and some people do them all. Yeah. I think the studies, there's only been 1 or 2 studies of randomised, controlled. One side got the patella and one side didn't, and there wasn't enormous amount of difference in the two, but that was done in people without severe patellofemoral disease. But if they've got severe patellofemoral osteoarthritis, I think they have to have the patella resurfaced.
And one more, if you have someone with bilateral needing both, do you do them at the same time? Do you give them a break between total knee? How do you approach that?
I do them a month apart. People argue about it. I mean, there's been some disasters about doing bilateral simultaneous totals because it was just a big shock to the cardiovascular system and the hemodynamic system. So I steered clear of it because of those issues, and just do them a month apart. It's just a bit safer, that's all.
Yep.
And then their rehab's only out of sync by a month, and they don't have to wait for months and do it twice. So I think a lot of people do it that way. The only downside of doing it that way is the risk of DVT. You're slightly hypercoagulable for more than a month, but probably up to 3 months after a big operation. So just a slight negative on that one, but yeah, it's only slight.
It's hard on the post-op physios as well.
Yes.
And you get
that
2 knees that don't
down the bottom
move.
of the considerations.
Thanks, Richard.
That's right.
All righty.
Thank you.
Thanks, mate. Thanks, Richard.
Thanks a lot. Appreciate it.
Thanks for coming. Thanks for attending.
Thank you. Excellent.
Brilliant. All right. See you.
Thanks,
Bye.
Bye.